Be seated, thank you. Okay? So there are tons of you, so even if only one person whispers, we will not be able to hear each other. So we need complete silence. So, today's session is going to be about something called drug metabolism. I'm in the pharmacology department. My name is Dr. Barra. I will be covering something called drug metabolism. Now, in order to talk about metabolism, the first thing we need to do is we need to know in which perspective does metabolism relate to pharmacology. First of all, there's something called pharmacology. Pharmacology means simply the science of drugs. So how do chemicals or drugs interact with our body, and how does our body interact with them? So the interaction between a drug and the human body or a living system is called pharmacology. Pharmacology mostly covers two main aspects. If this is a drug and this is me, there are two possibilities. Either how would my body affect the drug, or how would the drug affect my body? So the effects that my body do to a drug, they're called pharmacokinetics. And the things that the drug does to me are called pharmacodynamics. Now the things that the body would do to a drug are, if you would take a drug orally, if you would swallow a tablet, the first thing that your body would do to that tablet is it will try to absorb that tablet. Then eventually, after absorbing it, it will try to distribute it in different parts of the body. Then it will try to metabolize it, and then it will try to eliminate it. So these four steps are pharmacokinetics. And in this lecture, we would only talk about one of them, which is metabolism, which is the topic of today. So, to repeat what we have just said, if you would take a drug, for example, orally, the drug will first be absorbed, and then it will be distributed, then metabolized, most likely by the liver, but maybe it can happen anywhere, and eventually eliminated. To add to that, there are extra steps that we skipped. For example, before absorption of a drug, if you would take a tablet orally, before the tablet can be absorbed, it must be what? Must be dissolved. And before it would dissolve, it must be disintegrated, meaning that it must be broken, then dissolved, then absorbed. And when it comes to metabolism, it doesn't always happen. But in most of the cases, it happens. Sometimes we don't need metabolism. We would get to know when we would need it and when we don't need metabolism. Now, the drug metabolism, it can happen as soon as the drug enters your body. Sometimes, even if a drug is in your mouth, you have certain enzymes in your mouth that can start the metabolism. But of course, the major site for the metabolism is going to be the liver. Why do we need metabolism? We need to think before that. For a drug to be absorbed, for something to cross membranes, do we need that thing to be hydrophilic, or do we need it to be lipophilic? If I want it to be able to get through membranes, it must be lipophilic. So most drugs, if we want them to get everywhere, we want them mostly to be lipophilic. Okay. So lipid-soluble drugs, they are very good for being absorbed. But this is good when you take a drug orally. But when you want to get rid of the drug, now this is a problem. Why? If we take a look at this thing this thing that we're seeing here is supposed to be a what? What is this? What is this thing? It's a nephron. A nephron is the functional unit of kidney. So the kidney is simply a lot of nephrons. How do they work? A drug is brought into the Bowman capsule. If the drug is lipophilic or small in size, it will pass through the Bowman capsule. If it's not good enough, if it's large or something, we can actively secrete it. Now everything that goes in this way, eventually, hopefully, will go with the urine and we can get rid of it. Anything that goes down here. But the problem is, most drugs are lipophilic. And if a drug is lipophilic, it will not stay here. It will be reabsorbed because it's lipophilic. So just like initially it was easily absorbed, right now in the kidney, it will be easily reabsorbed. It will go back to the blood. And we cannot get rid of the drug. So the drug will stay in the blood. As a result, we need to do what to eliminate the drug? We need to metabolize the drug. We need to change the lipophilic drug into a more hydrophilic form so that it's not reabsorbed, it will stay here and it will be eliminated with the urine. Hydrophilic means ionized and lipophilic means non-ionized. So far, do you want to ask anything? So the reason for metabolism is we want to stop the reabsorption of lipophilic drugs by making them more hydrophilic so that they could leave with the urine. This is the main goal for metabolism. So it's a protective mechanism. The metabolism usually happens with something called phase 1 and phase 2. And by the way, metabolism not always deactivates drugs. Sometimes they activate certain drugs. Such drugs are called prodrugs. What does that mean? For example, the drug codeine. Codeine is an opioid. Mostly it is used for what? For cough. Codeine, despite the fact that it's an opioid, but it can help with cough. How would it work? When we take codeine, it will be metabolized by demethylation. So the methyl group is removed and the codeine will become morphine and it will work. So in this example, what we've learned is metabolism does not always deactivate drugs. Sometimes it activates them. And such drugs are called prodrugs. For the phases of metabolism, I told you there was something called phase 1, something called phase 2. Phase 1 is simply small, simple chemical reactions like oxidation, reduction, hydrolysis, and some certain cofactors like NADPH would help. These reactions are conducted with a group of enzymes that are called cytochrome P450. A huge family of enzymes in the liver, they conduct these chemical reactions. Phase 2 is simply adding large polar molecules. So it's not a reaction. We bring something large and we combine it with the drug. When we combine two things together, we call that conjugation. Like, for example, conjugation with glucuronic acid. In summary, what we do is, if we get a drug, like for example, aspirin. Aspirin is acetyl salicylic, so this is acetyl, and this is salicylic acid, or this is again salicylic acid. This is called aspirin. Mostly it can be used for pain, for inflammation, or for cardioprotective purposes. When it comes to metabolism, we get aspirin, and we would do one of these simple chemical reactions. So this was acetal. The acetal has been removed. Currently it's hydroxyl. So this is a simple deacetylation reaction. This is a phase 1 reaction. Just a simple, small chemical reaction. The idea is we're going to get hydroxyl. What would we get from hydroxyl? What would we benefit from getting hydroxyl?
Polar.
It is something polar. We're changing the drug into something more polar. In phase 2, what we did, phase 2 was conjugation, binding two things together. So they brought this huge glucuronic acid molecule and they bound it with salicylic acid. They conjugated them together. So phase 1 was simple chemical reactions, while phase 2 was a conjugation reaction. Let's take a look at the, What is the point of what?
Phase 1.
Phase 1. Phase 1, one of the ideas is it makes something more polar. Another idea is it makes a drug more reactive. Like for example, right now when we change this into hydroxyl, we made a spot for glucuronic acid to come and conjugate. Without step 1, glucuronic acid will not be able to bind to aspirin. So either it turns something into something more polar, so we can eliminate it with urine, or it makes it easier to conjugate. This is the purpose of phase 1. If we look at the huge molecule that we just added, which is glucuronic acid, we can see that it is rich with what? What does it have? Hydroxyl and carboxyl. And these are, just like we said, they are polar groups. So when we add a lot of polar groups to a molecule, we turn it into a hydrophilic or ionized molecule, or a polar molecule. So this is the purpose of metabolism, and this is why we do it. And this is how it happens. Phase 1, phase 2. By the way, not always it happens. Sometimes we don't need metabolism at all. Sometimes you only need phase 1. Sometimes we only need phase 2. And sometimes we need both of them. So this is the core of today's lecture. Any questions so far? Okay. Now there are certain factors that can affect metabolism. So other than the process itself, before it happens, some factors can play with it, like genetic factors or environmental influence. So if you are from the Middle East, or you are from China, or if you're from the Mediterranean, or if you're African, each special group of human beings, they have slight differences in their enzymes. And these slight differences can make them have different response for drugs. So a drug that is good for me, maybe it's not good for you. But since we're all from the same region, then most likely we will have the same enzymes. But maybe something that is good for me, it will not be good for someone from China or someone from Africa. So this needs to be taken into consideration. There are certain tables. For example, someone has hypertension. They say this person is Asian, give them this group. This person is African, give them another group. Depending on the ethnicity, the enzymes would change, and the efficacy of a drug would also change. Also, the environment can play a role. Let's take a look. When it comes to genetics, as I said, they can be different depending on the area that you're from. So for example, there are certain people that are called slow acetylators. Certain people, they have slow acetylation enzyme. Some people are called rapid acetylators. They have a lot of enzymes for acetylation. So they would metabolize a drug at a different rate. If we look at this diagram, it says rapid acetylators, in 1 hour they can acetylate or metabolize the drug isoniazid. So within 1 hour, most of the people who are rapid acetylators, they metabolize and destroy the drug isoniazid. while people who are called slow acetylators, they need 3 hours to metabolize the drug. So the idea is, if someone is a slow acetylator, should you give them more drug or less drug? They are slow acetylators. They need a lot of time to eliminate the drug. Should you give them more or less? Less. So the idea is, depending on the enzymes of that person, the dose of the drug might need adjustment. And isoniazid, by the way, is a drug that is exclusively used for something called tuberculosis. So far, any questions about the genetic variability? Yes? No, acetylation is like, the conjugation happens with large pieces, like for example, glucuronic acid, something large. While acetyl is a small piece, and it's not that polar. So it's a simple chemical reaction, not conjugation. The COCH3 bond. That's called acetyl. Yes? Okay. Okay. We talked about rapid acetylators, not slow acetylators. Oh. If someone is a slow acetylator, they would need, they slowly destroy the drug. So the drug will stay in their body for a long time. So I need to give them less because they are not getting rid of the drug. Instead of giving them the drug 3 times a day, give them the drug once a day. Because they are not destroying the drug, they keep the drug in their body. If I give them more, I will give them a toxic dose. While people who are rapid acetylators, they destroy the drug and throw it away so fast. They need more. It's as simple as that. Anything else? Okay, so yes? They would eventually metabolize it, but slowly. And the benefit doesn't come from metabolism, the elimination comes from metabolism. If a drug was a pro-drug, then you would need metabolism, but pro-drugs are rare. Anything else? Okay. So we come, yes? Okay, let's talk about this after this session. So let's try to move on slightly, take a few more slides. So we covered the genetic variability. Another issue is something called environmental influence. There are certain things that we can take from the environment that affect the enzymes. For example, there are certain drugs that can induce metabolism or can inhibit metabolism. There are certain foods or drinks, like for example alcohol, that can influence metabolism. So all of these things together should be taken into consideration. For example, ethanol barbiturates, they induce enzymes, while erythromycins and ketoconazole, they inhibit enzymes. So the enzymes are inhibited, there is no metabolism. When there is no metabolism, should we give more drug or less drug? Less drug, because the drug is not being metabolized. It's not being eliminated eventually, so give less drug. There are certain drinks like grape fruit juice or certain herbs that can still. So everything must be taken into consideration before giving drug, because anything can play with the rate of metabolism. This diagram shows us that drugs, they can go through phase 1, or they can skip and go directly into phase 2. Or sometimes we do both. This is the only thing it shows. A very, very important definition is something called first pass effect. Instead of reading the text, let's just take a look at the diagram that would explain what is first pass effect. If you would take a drug orally, the first thing after being absorbed, where would the drug go to? The liver. This happens by something called the hepatic circulation. Why would a drug or anything, if you'd have food, the first thing it would go for the liver? Why would that happen? Yes, it's a protective mechanism to protect us. Whenever we take something, the liver checks it. Is it toxic? Can we take it or not? So certain drugs, if they're given orally, when they go to the liver would metabolize the drug completely and the drug will not work. This is called first pass effect or first pass metabolism. As soon as the drug enters the body, it will be destroyed and will get no value. In order to bypass that, we can try and give the drug by a different route. For example, we give the drug IV, intravenously, directly into the blood. By doing so, we would bypass the liver and we would protect the drug from being metabolized. In the previous slide, there was an example of a drug that's called nitroglycerin. You know what is nitroglycerin used for? If someone has angina, they have pain, and they would eventually get MI, they can take nitroglycerin. It would cause vasodilation, and it would relieve the pain and prevent the MI from happening. Also, nitroglycerin can be used as explosives, by the way. So, if the drug was swallowed, it will be, 90% of it will be destroyed. But if it's placed sublingually under the tongue, it will immediately go into the blood vessels and it will not be metabolized, mostly. But some of it would still go with the sputum and will be swallowed. Also, if you place a drug under the tongue, directly into the capillaries, that drug will also work rapidly. So that is another advantage. So again, any questions about the environmental influence or about the first pass effect? Yes? Okay. Guys, again, for the, fifth time, complete silence. Okay? There are a lot of you, and we need complete goddamn silence. Okay. So whenever we take anything orally, that thing, if you take food, the first thing after absorption, mostly by the intestine, the blood containing the drug or the food, it will go to the liver. Why that happens? It happens to protect us. Detoxify anything that is absorbed. In certain cases, with some drugs, the drug, when it goes to the liver, it is completely destroyed. Not all drugs, some drugs. As a result, these drugs should not be given orally. If you take paracetamol orally, would it be totally destroyed? What do you think? No, because we already see tablets of paracetamol. If it was destroyed, then why people take tablets of paracetamol? So this is what we mean by first pass effect. The first time something enters the body, it can be destroyed. Any questions? Yes? Let's keep that for after the session because I can't hear you. It's not an advantage, it's a problem. Yes? Yes? Yes. So we have finished the, let's keep the question after the session because you're kind of far, I cannot hear you. Because all of your friends are chit-chatting. Okay? And it's impossible to control 300 people in such an annoying small hall. So, examples, talk about two main examples. We would mostly focus on alcohol, then we would talk about paracetamol. How are they metabolized? What can go wrong and what can go right? So normally, ethanol is simply alcohol. Ethanol is mostly metabolized by the liver. So this is ethanol. Ethanol by alcohol dehydrogenase would become acetaldehyde. It would also consume NAD+. And by aldehyde dehydrogenase, it would become acetate and eventually acetyl-CoA. So this is the metabolism pathway. By itself, I'm not concerned about it, but I'm concerned about the results. The results are a lot of NADH, a lot of acetaldehyde, and a lot of acetyl-CoA. Why is that bad? Because if I would get a huge amount of NADH, the ratio of NAD+ to NADH would decrease. When this ratio would decrease, this means I will not have enough NAD+ to convert lactate into pyruvate. Why is that bad? It is bad because if I can't convert lactate into pyruvate, I will not have gluconeogenesis, and I will not have glucose, and I will get hypoglycemia. So this is one problem. Another problem is if I don't have enough NAD, I will have more lactate in my blood because I can't convert it. If I have more lactate in my blood, I would get something called lactic acidosis. So the pH of the blood will be ruined. And if I get lactic acidosis, I can also get uric acid precipitation in my joints. And this would lead to a condition called gout. This is why drinking alcohol by this mechanism of decreasing NAD+ and increasing NADH would cause all of these problems. Hypoglycemia, lactic acidosis, and eventually also gout. This is one problem. The metabolism of alcohol can lead to toxicity. Any questions about that? Yes. What is the cause for that? There is no gluconeogenesis. We can normally create glucose. When you don't eat, you need to create glucose. But you cannot create glucose because you cannot convert lactate into glucose. Anything else? So this was one problem. Yes? Yes, if you stop the alcohol, eventually it would fix itself and fix the ratio. Well, it would still damage you, and eventually the body would adopt, and you'd get something in between. Yes. So one problem was, yes? Yes. It could help, yes. But if you're sleeping and you're not taking glucose, your body would create glucose for itself, but it cannot. Yes. So this was one part. Another or second part of the problem is the alcohol would create a lot of acetyl-CoA. When we have increased acetyl-CoA, we would have a lot of fatty acids in the liver cells. The fatty acids would cause two problems. Either will be converted into triglycerol, causing something called fatty liver, so the liver will be filled with fatty acids coming from acetyl-CoA, or they can create something called keto buddies that would cause something called ketoacidosis. Again, it ruins our pH. So this is the second problem. Ruining the pH and causing fatty liver and destroying the liver. A third part of the problem is whenever people take alcohol and their liver is damaged, they would get a lot of ammonia because it's not being, ammonia is converted into what? So we can urea. So there would be no conversion of ammonia into urea. I would get tons of ammonia. This is called hyperammonemia. If you take a blood sample, you will see there are a lot of liver enzymes in the blood. Why are there enzymes in the blood? The liver is damaged, so it leaks. The enzymes leak from the liver, they go to the blood. I will get minimum protein synthesis. Proteins have a lot of applications. For example, they play with the density of the blood, like for example, albumin, the viscosity of blood. If the blood is not viscous, it would start leaking. Proteins, they play a role in the coagulation. They have tons of roles. So I would get edema, bleeding, fatty liver, all because I cannot synthesize protein because the liver is damaged. I will get high levels of bilirubin because bilirubin should be conjugated with glucuronic acid so we could urinate it. The liver is not working, I get tons of bilirubin. And of course, bilirubin is the byproduct of what? Destruction of RBCs. So all of these lines will be damaged. Another fourth mechanism of damaging is drinking alcohol would damage the GIT and would ruin the appetite. As a result, you will not be able to take vitamins. If you don't have folic acid, then you will get anemia. What kind of anemia? Megaloblastic anemia. If you don't get vitamin K, you will get bleeding. Why?
No clotting.
Because vitamin K is a factor in the coagulation process. There is something called pyridoxine, something called thiamine. Pyridoxine is vitamin B6 and thiamine is vitamin B1. They both play an important role in neurological conduction. If we don't have them, then we will have neurological issues. So as we have just observed, all the systems are ruined by consumption of alcohol by different mechanisms. Some of them are direct, some of them are related to metabolism. Do you want to ask anything about these mechanisms? Yes. Because of alcohol consumption, there will be damage to the GIT. When we have damage to GIT, we will not be able to absorb vitamins. When we don't get vitamins, we get problems. Anything else? Yes? Let's explain it after the question. Anything else? Okay, so in order to be able to control the addiction of alcohol, a drug was created. That drug is called disulfiram. How would that drug work? Alcohol is converted by alcohol dehydrogenase into acetaldehyde. The acetaldehyde causes something called hangover. Hangover means simply a series of very, very annoying symptoms, mostly headache, maybe vomiting. People who drink a lot of alcohol would get that. So if that person is given a drug called disulfiram, it would keep acetaldehyde in this form. It will prevent the formation of acetate. As a result, that person would keep on getting headache. Eventually, they would give up on drinking because they're getting horrible side effects. So this is a trick where a drug plays on the metabolism of alcohol so that it can help people stop drinking alcohol. The final slide that we would talk about, by the way, there are tons of other things that we can talk about alcohol that are very important, but obviously the condition right now isn't very good. This place is horrible, so I'm not willing to explain them. The last thing that I would talk about is paracetamol. Paracetamol is an extremely important drug, as we all should know. The metabolism of paracetamol depends on the dose. Normally, if you would take a small dose of paracetamol, also known as acetaminophen, which is same as paracetamol, will either go to the sulfate conjugation or glucuronic conjugation and will be eliminated. Some of it will form this intermediate. This intermediate is hepatotoxic. It damages our liver. If you have taken a small dose of paracetamol, then your body would use glutathione to destroy this. So glutathione binds to this toxic intermediate and eventually we can get rid of it. But if you take a high dose of paracetamol, then the glutathione will not be enough. There would be a lot of this intermediate. This intermediate will attack the hepatocytes and kill them, causing hepatic failure. And this is the biggest problem you could get from paracetamol. It happens at a high dose of 4 grams or more. And we are done. For those who have questions, come here and ask.
طبعا زيادات منو ما يجيش مكان لنا وهو هم ما تركيز كيلو أقرب تشتغل بس ما طلعوا تبسكت طلعوا ده زرش
Today's session is about biotalenia. Yaktos bedang من biotalenia. هرنا مو مايك كوكان. هذا عندك يا بوي. باش كده. وياك مرس مايك كوكان والله بولوشتي وكم كنا والله شو نبين فوتنا.
Today's session is about metabolism. This lecture is an overview of what you have got so far in terms of protein metabolism, fat metabolism, carbohydrate metabolism. Now we are not going into the details and enzymes of metabolism. We are looking at the metabolism as a whole in terms of fasting, feeding, status, and hyperglycemia, hypoglycemia.
So aims of today's lecture is fuel concentration, that's to say glucose level, fat level, protein level in the circulation, hypo and hyperglycemia. If this balance is impaired, there will be development of either hypoglycemia or hyperglycemia. We are talking about normal individual. This balance should be maintained every time, during meal and after meals. If it is impaired, the patient will be at risk of getting hypoglycemia or hyperglycemia according to the abnormalities they have. We're going to talk about fat and fast state of people. So first of all, fuel concentration is controlled by hormones. We have several hormones that control fuel concentration. We have insulin and anti-insulin hormones. ورا بيشو الله كده ورا بيشو كي جوالين يا جماعة دتواني شو لك أوه سوري إيه باشا وتامن بكاري أنا إيه وش قسمك عن طاوة إيه باشا
We have insulin that lowers fuel concentration, and we have other hormones that increase fuel concentration. Other hormones like glucagon, adrenaline, growth hormone, and cortisol, so they are called anti-insulin hormones or insulin counter-regulatory hormones. And you can have it because their action is opposite to insulin. Diversity of fuel, we have first of all glucose. Glucose can be used by all cells as the preferred fuel. Very little free glucose is available in the circulation now. Each individual around 12 grams. That will support the metabolism of the central nervous system for 2 hours. Yani each hour 6 grams of glucose. ماشي كم ساعة نكاوة؟ كم؟ Yes. Kawata Perisaka continuous supply of glucose man have to maintain normal brain functioning. Around 300 grams is stored as glycogen in liver and muscles, but only the stored in the liver, 100 grams, can be made available to the central nervous system. أو ساعات بتشي كنا كأوصل جراما. هالجرامة هال ساعاتك 6 جراميات. 12 ساعات 10 hours around, yes. آخر other cells, other glucose dependent cells man هي واجد نفتكر ولا. لو بشي around 12 hours تقريبا. Many cells can also use fatty acid, but red blood cells, central nervous system, and some cells in the eye and in the gonads, they are glucose dependent. They utilize glucose only. We have fat. In a typical 70 kg individual, there is 10 to 15 kilogram fat. Which is enough to supply body's fuel needs for about 2 months. So 80% of the reserve fuel is by fat. تصوري معك جماعة كيف تصوري معك؟ كيف تصوري معك؟ أتوقع حسابي كان هذا كيلوغرام فات شن كيلو جول يا individual كل روجا كابيسي بتشنيه أو كاتة تقسيمها كأكيد تقريبا 50 روجات. هو بلاتنا قريب نبي جاري كسر دوزنا وتشان روجي تيزور ناني نخواردو مانيا كابيز روجا شل روجا still alive. Yeah, فبس aware 80% of the reserved energy is from fat. شرقية هم يبكاربين يعني كسكة هم يبكاربين تان بس هو إن amount energy كبود تحديد كبود visualizing utilization. Fatty acids can be converted to ketones and in the liver to be used as fuel by the central nervous system and other cells. And fatty acidic كمان convertible ketone bodies. Ketone bodies can be used by the brain in times of shortage. هالكات النقصاني ما هبو glucose كبو brain شوي adaptation كابوي incorporate ketone bodies. We have protein about 6 kg in a normal individual, 70 kg individual. They can be broken down by proteolysis to amino acids and provide fuel in times of shortage for about 10 days. يعني energy كهيتي بشي 10 days كا. أما جتوان الشاشة كرتي حفا أزاريكا. دعاء وتشر رقم كا تقسيمي دكا كاتب دربش تقريبا هو لبري 10000 كيلو جول مانع لبروجكت CNS depends on glucose to produce energy. It has to be available at all the times as CNS utilize 140 gram per day. Normally, you have glucose bakareni, 10 gram, 180. How we filter a bit to the kidney, absorption or circulation. 140 gram to the brain, central nervous system, that's to say, and 40 gram to other glucose-dependent tissues. The rate of glucose uptake by the central nervous system depends on what? The concentration of glucose. It means what? When we have low concentration, there will be less uptake by the brain cells. When we have normal, there will be normal uptake by the brain cells. When we have high increased amount of glucose, there will be increased uptake by the nerve cells. That's why sometimes, not sometimes, majority of patients with uncontrolled diabetes, hyperglycemia for prolonged time, they develop nerve injuries because glucose enters the nerves and there will be some damage to the nerve cell metabolism as well. A healthy individual, healthy, glucose حفتايا بوصل ده أقل fasting bit أقل كسكة fasting و post prandial هربي collectively خسر كين على normal range 70 to 139 تعصب سيونو أو كسي كناني خوارد أو كسي ناني نخوارد لما يرجع ياريك أو كسي كشر ساعة زيادة يعني هر ساعة ناني نخوارد شكل كيسا قياس كين 70 to 110 درجة. Got 4 to 6 millimole. The blood glucose is طبعا millimole كرتي هجية كي كاتو مليغرام per deciliter كي خبر. The blood glucose is controlled by neuroendocrine system. It is very important to have a very normal and very critical control of fuel concentration to have normal metabolism. Suppose that when a patient is having problem in metabolism, cannot maintain normal fuel concentration, so they are at risk of either hypoglycemia or hyperglycemia. Now we talk about hypoglycemia. We have different terms, different limits to define hypoglycemia. بأما كتبين بينو سنة إخوة. ما بود جاليات لك دكتور كتاب ناقش شاقي بسار اللي كاتو مالي وشتكي ترى الله ما بيزانا. All the guidelines, all the schools are agreed that a blood glucose level of 54 or less is called hypoglycemia. هم مثلا موافقين. هني سكول تنهي على ليرزان 65. ليش أسبيش كم تربيت؟ هي على ليرزان 63. هي على ليرزان 70. هم معنا براسنا. ليرزان 70 هر hypoglycemia. ليرزان 63, 65 and 54. بلا هم سكولك كزنية بما بلا normal. ب 54 and below بلا normal. نبرم رقم من ده. أمانة محاضرة كتانية بس حسب كل أديك مشكلة صارت عندها توهري فعلا. When we diagnose hypoglycemia, we have a trial called Whipple trial. دو كلمة بينوس رسمي مقربة. دو كلمة بينوس. Whipple trial شيء. بوتانا ده رسم مقربة. Whipple trial شيء features of hypoglycemia. نخش على feature hypoglycemia هي. أما يك. trial يعني شيء يعني سيانة. أما يك. documented hypoglycemia يعني كبلاد تيستك معمول كردو لو كاتاك نشانة كاني هي glucose level low بوا نزم بوا أما دو Number 3 is recovery after normalization of glucose. كانت الشكل بي شاكي بيتو سنت مكاني نعمل. هالكسي أم سياني هو أما بيوتد Whipple triad of hypoglycemia. Acute effects of hypoglycemia. If someone develops hypoglycemia, chilate. أما زور أبينا وكو كيس بعد أشخاص خانة كانوا تعينا بالإيجا كان ينخز من الناس يلي كخوتان توشي دا غزيري الشكل أبيد أي بينا. The patient developed trembling يعني ألم زيت طلع weakness بيهز أبيد شكل أبيد tiredness as well headache سري شيء هي ولا بروي برينس يلا كان ناتوان وبيس energy وقدر sweating tingling around the lips اللي هو لرزو عرق النوع a bit palpitation delectate a bit change in mood anger and bad temperature أبيد برايك لنا جماعة الله سير بشتكى كان زور غريب وعجيبة نابي وكا أما احتمالا شكري داوزير بس وانا كان يوم نشر تمام جاري وانا قاوشة قولنا كلينيكا أو أنا كلينيكي بزوري نخوش شكل عبيني نبرا نخوش شكل هايبوغلايسيميا أجر شتكي زورك نورمالي كير زاني أما لقلو تمنى أو إيجو أو كسرنا كنجب زانا ما احتمالا هايبوغلايسيميا توجد slur speech, secondary temperature, confusion and abnormal staggering walk. روشنا كشي بباشين ناتوانا بروا يعني هم feature to different extent can be available in cases of hypoglycemia. It can rapidly lead to unconsciousness and death if left untreated because CNS is starved of glucose. يعني this is top emergency condition. It should be recognized and treated very quickly. We have in non-diabetic patients. جماعة أنا هاوكاري كان كابسانة تركيز كذا. يبغوا يفيد من المستقبل يشتغل شكل جاهل. In non-diabetic patients. بس يوانا كيف شكلها النية. Hypoglycemia can be classified into two types. Number one is fasting hypoglycemia. Fasting هو يكتشن ساعات كلامي نخواردو إنجا شكل دعوة دوای جمعان باشا. Relatively باشا. اشتكت معنى بيوتر reactive hypoglycemia. أمانة شيء they have hypoglycemia after meals. Today we are not talking about reactive or postprandial hypoglycemia. بس هناك كدوای نخوارد شتان دعوة بس يوم تايبا كي كبريتيلا fasting hypoglycemia. يعني شيء يعني before the next meal they develop hypoglycemia. At night they develop hypoglycemia. At morning before breakfast they develop features of hypoglycemia. أما بس يوم كي ساكن. أما لما حضرك أنا بو بس بوي هنا وما تم حضرك ولا بري لجروب سيشني ده هات ويان ده هات ترى هي بوي هاوكاري تام كين شون تيجي على موضوعك بوي بنقص هنا ما نام حضرك. Basically, why people develop hypoglycemia? Because abnormality of carbohydrate metabolism, either too much glucose is being used or too little is being produced, or both. يعني زور utilization كحديث normal زيادة. يعني ناتوان story cut. يعني نتيجة. In response to fasting, normally, أجر يمكن إما جماعة دستات جماعة تيجي زور لو أشوف fasting بينه رواية. إما we have 3 meals, and in between meals we may not eat anything, and we can perform daily activities. روجاني تريش بيرجع fasting رمضان. إما تستيرش بنا نخون بس هم يشكلنا كي. من أوتر بالينا نخون تالي رونا نخون دوامك. توهر روايكي. أما feeding fasting cycle. Normally, the glucose level should be maintained above 55 milligram per deciliter. يعني أجر توزك إجدار وزيدنا بهذا الكنترول بينش كرتب. هو number 1. Number 2, PS should be maintained in normal range. 7.4. lactate and pyruvate level should be constant or decreased. Why decreased? Because they are used, by the way. These are normal responses to hypoglycemia, fasting hypoglycemia. I mean, when people are not eating for a few hours. Maintaining of glucose level above 55 milligram per deciliter for 10 hours, 10-hour fasting, indicates that the liver glycogen metabolism is normal. يعني اگر بین چکی کینو کسک فاستینگ رمضان فاستینگ ساعت دو چکی کی بلا سامپل کی بو کی glucose کی 60 بو يعني above 60 بو it means that the patient has normal glycogen liver glycogen metabolism. چکان چند ساعت پیش ما بچیه با liver glycogen store. But if the patient develop acidosis, this is abnormal. If the patient develop very high lactate or pyruvate, they are abnormal. So the normal response are these. If the patient develop low pH, this is called metabolic acidosis, they may be associated with hypoglycemia, in our case for example, caused by the presence of acidic metabolites like what? Lactate, pyruvate, amino acid, fatty acid, and keto acids. أما أنا كزيارون شيئا acidosis دروسا كان pH دار بس النخبار هو أما abnormal. When we investigate patients with hypoglycemia, generally talking, not only fasting, we need to take history and do examination and perform some blood tests. هل هم all together شيء معناته again a diagnosis. Sometimes the patient نكتشيا insulin inject يدايكي نيكي شو ذات. أيبين أنا أوروبا لهذا هي للدروزيات. يعني شيء كده medication كاني نخوش كي بكارنا. أما بوتوي hypoglycemia. يعني أما لا رجع history أو تواني تشخيصي. كلام شانو كده أو investigation biochemical investigation ما هي فورماليكيا وكوتشي. When does hypoglycemia begin? Is it after meal? 1 hour after meal? 3 hours after meal? Agora. Or it is fasting hypoglycemia? After 6 hours, for example, 10 hours? Amen. What metabolites are producing acidosis? Ketone bodies here, other fatty acid here, OI3 here, lactate here. Measure blood levels of metabolites at various stages during fasting. At some cases, prolonged fasting intervally, the time interval جوازه testing sample blood or agree boy measure يمشان glucose level measure كي لهمان كاتا هرمون كان and metabolites. Okay. We measure what? Plasma insulin and glucagon, cortisol and growth hormone. Can somebody tell me during hypoglycemia the insulin level should be what? High?
Low.
Normal should be low. Should be very low because the patient developed low glucose concentration now, having low concentration of glucose. The insulin level should be very low. جماعتي جوا مشغول يجيب. يقول لك ماني زاني. Okay, if the patient is having increased insulin level at that moment, it means that the cause of hypoglycemia is insulin oversecretion. America. Normally, now I'm talking about normal person. The cortisol, growth hormone, and glucagon during hypoglycemia should be what? Should be high. If one of these hormones are low during hypoglycemia, it means that the cause may be deficiency of that hormone, for example, growth hormone, cortisol deficiency. Okay, so these hormones are helpful in determining the cause of hypoglycemia. We measure enzyme activities in the red cells to detect some kind of metabolic problems. We evaluate what? Glucose utilization and gluconeogenesis. Slide إذا هاتوا بس أماكن. طبعاً هسه برسالة أنا في الله هو gluconeogenesis نيو بيطلع لنشيو. كي تو أنشتك من السلام أبو باسكا بكرتي. كذا توانه. This is called glucose tolerance test. Indication is or we have a lot of indications of glucose tolerance test. One of the indication is to measure glucose utilization. Is it okay or not? Now we are talking about this. For diabetes, this is time and this is glucose concentration in milligram per deciliter and in millimole. First of all, the patient is at fasting state. 8 hours, we check blood glucose at 0 time, there will be 72 milligram per deciliter, which is normal. Then we give glucose, 1 gram per kg. Then we measure glucose level in time interval every 30 minutes. It should be reaching the highest concentration at 1 hour. وكون كيس الخوضة وبصل بسوشر still within normal range. South normal and return back by 2 hours to the baseline level. This means that the glucose utilization is normal. Why? The glucose is being uptaken by the cells. If it is extra, the need of the body will be stored as glycogen. So I think utilization is normal. Test المان هي بيوترشي أما الشكل أوعية هذا أم سلايدة شيء من بوكات evaluation of gluconeogenesis. Can somebody define what gluconeogenesis is? Yes. So, making glucose from non-carbohydrate sources. Basically from glycerol and from amino acids, yeah? طبعا نفس الأداة اشتكي ترمان هنا قال لاكتوز يشمل هنا لقى فركتوز لما نجيك خط أنا هي عنده أنا بو أوله هنا باسي gluconeogenesis بوكا باسي metabolism بوكا وجنرال بس نفس الأداة باسي بس ليه جليسرول ده بس يجي gluconeogenesis نفس الأداة شيء ما فيها سيكون جماعة blood glucose concentration after oral galactose يعني أهم شيء رقمه all are glucose levels بس level glucose again nothing else but here when the patient has got galactose كانت galactose يعني أنا خوش كمان أمان يكمل second هنشيا كانت fructose يعني أوتي أمين أخي هنشيا كانت glycerol يعني أوتي زين أتواني metabolism يمانك أو convert يعني كانت glucose second جماعة at 0 time 4 millimole 4 يعني half thousand وبتشن دو سي دخل ليرة لكيسي galactose كده وبتشن yeah 6 كواتا increase ووالا it means that the patient can convert galactose to glucose. So the enzymatic pathway of conversion of galactose to glucose is normal. Okay. What about here in glycerol? Glucose level 4 بوا. دو glycerol يورجتوا حتى بوا ب4 كم تريش 7.6. It means that the patient cannot convert glycerol to glucose. So the patient is having problem in gluconeogenesis. أنت أقرن بو إنزيمي كمشكلة هي. This is not our aim of today to talk about the enzymatic pathways. So the response to galactose is normal here, while the response to fructose and glycerol are abnormal, such that they cannot be converted to glucose. When the balance is impaired, the patient either develops hypoglycemia or hyperglycemia. We've talked about hypo, now we talk about hyperglycemia. Hyperglycemia means elevation of fasting plasma glucose to 126 or above, means that 7 millimole per liter. اگر فاستین لصو 26 زیادتر بود defined as hyperglycemia. Hyperglycemia can reduce both quality of life and duration of life. يعني شيء يعني quality life بنخوش كمان بأخرى فقط diabetes أما hyperglycemia persistent hyperglycemia is defined as diabetes أقل persistent. Quality life and duration life is كما كاتو. The nervous, cardiovascular and renal system may be affected in cases of prolonged hyperglycemia, prolonged diabetes, uncontrolled diabetes. The heart can be affected, the nervous system, the kidneys as well, and the eyes. There is glycosuria or glucosuria, means glucose in urine. Is it normal to have glucose in urine? No. Sometimes, any genetic disease man normally it should be absent. The patient develop polyuria. Yes, increase amount of urination, amount of urine production. Polydipsia, thirsty. They drink water more than normal. They feel thirsty and hesbatunia. Hyperglycemia can have other effects like enzymatic glycosylation of lipoproteins and impairment of their function. يساواني خوتون يكتوس خبري عن بيتوشكم موضوعك شفته كاين اشتيك او بشتيكي تر موضوعك هي زور انتريست لانه عيش في fed and fast cycle or feeding fasting cycle. Every day, normal population have several repetition of the cycle. During meal, we eat. So during feeding, there will be absorption of glucose, amino acids, and lipids, and these will increase their concentration in the circulation and activate the beta cells of the pancreas to secrete what? Insulin. So there will be insulin release. Insulin increases glucose uptake and utilization by the muscles, by adipose tissues, during feeding, and cycle. Promotes storage of glucose as glycogen in the liver and muscles. Utilization ziyakat, storage cheated promotes amino acid uptake and protein synthesis. That's why sometimes muscle gaining can insulin مكانه. دول بروي anabolic hormone. Uptake هين زيادة protein زيادة بنا مصلحة. Insulin promotes amino acid uptake normal basket. Insulin promotes lipogenesis and storage of fatty acid as triacid glycerol. Basi check itu, basi check. Legal money, azani. Hoja riwayat kasih. Malah mencuri nahum, kau syahwat nahum, berdiri wana nahum, curi kan syakrakam, berzab curi shemberzab. لەگەڵ تۆم بۆچی بەرزە سەرچاوە فاتەکان هیچی ناخۆ کاربۆهیدرات دەخەوە چەوریشم بەرزە ئەم سلایدە باسیەوە ئەڵێی کاتێک کەسێ نەخۆوە ئەو ئێکسترا باڵێن ئەو شوگەرە زیایە ئەوەی سم of the sugar will be utilized ئەوەی زیاترە لەوە stored as glycogen ئەوەی زیاترە لەوە converted to yes fat لەبەرەوە کەسەکە ئیکا بەچی Pharmacology answer fatty acid as triglycerol لەبەرەوە triglyceride زیادەکات هیچ سۆرسێکی نیشی نەخواردەوە باڵێ فات وانە بەس conversionی extra carbohydrate to triglycerol ئەم کەسە نانی خوارد insulin secretion زیایی کرد ئەم شتانە ڕوویە یەک تا خوارد now is the time between meals 6 ساعتی تر نان ناخوام کەسە تا ژەمی داهاتوو چی ڕۆیە during fasting there will be some reduction in glucose level هل within normal range جماعة abnormal نية على حفتة بوصل ذكي some glucose reduction this low level of glucose low normal يعني كم يعني هشتا يعبرونه يعني أنا حفتة تصاونه شكلي وكسكاغات حفتة بين هشتا there will be inhibition of insulin secretion insulin secretion ما كمبيته low blood glucose concentration also stimulate what glucagon secretion so we have low insulin anti-insulin ratio insulin anti-insulin ratio چی لیاتو کمی کردو چون لیبل insulin ما کمی کردو گلوکاگونش که anti-insulin هورمون و جماعتکی زیاد کردو ratio کمان کمی کرد whenever we have low insulin anti-insulin ratio there will be number 1 glycogenolysis أو glycogen كستور كلا أو بانكريات أو circulation نبات أو glucose lipolysis from in adipose tissue to provide fatty acids cheater gluconeogenesis all these steps will maintain the glucose concentration within the normal range and fatty acid for the other tissues. Glucose to the brain and central nervous system, I mean, and fatty acid to the other tissues. Amalekaya during fast. But if fasting is prolonged, we have another terminology, starvation. So starvation basically is fasting for more than 10 hours. يعني وكسر الرجوع بيت لدوي ساعات دو سوا أشيتا مرحلة starvation أو زين شيء رأي starvation at first there is some reduction in the blood glucose but should be maintained above 63 بولا كسر normal shaky blood glucose pain the 63 زيادة by the action of glucagon will stimulate the breakdown of hepatic glycogen. And glycogen هي عادة بشي 10 ساعات يكم مانك. دو أو بgluconeogenesis روبات. overlap كان لقال يكم. أو glycogen هي 10 ساعات يكم يتداوم. وأي لقال يك يواش يواش كglycogen store كمان كم بيتوا. gluconeogenesis is دس بيكات. وأي ليت لكوتاي روجكا gluconeogenesis is the main actor. أو source كوري يقولي لك gluconeogenesis كوري. Low blood glucose stimulate cortisol, you know that, which enhance lipolysis and peristalsis. كواتلم كاتيا، شي مان هي؟ cortisol secretion إيش مان زيادة؟ أدرينالين وكورتيزول وغلوكاغون وغروث هرمون وما نهر هموي. وأكاد كشي بيت glycerol Alanin man bo available card the circulation to be converted to glucose. Second, free fatty acid لكاتي تيريا chane 0.3 millimole. أي لكاتي starvation 2 millimole يعني كان دعوة زيادة chane. زيادة. أما from lipolysis. يشتي تري مهم هي cortisol إشي كتريش من بوكر. It increases insulin resistance. It prevents what? Peripheral utilization of glucose. أو glucose كمية كهيا باش يخو brain أكاد يشتو ما نتوبه brain وأكاد مصل وري نجريت. بون مصنات وانا وري جريت لبري insulin اللي كم ما كما يعني أدنية زو كما لهما كاتا cortisol ما هي ك prevent utilization of the available glucose by the muscles for example. So it makes glucose available for the brain and the spinal cord. Both cortisol and glucagon stimulate gluconeogenesis. Glycerol is an important substrate for gluconeogenesis, reducing the need for breakdown of proteins. أما نوع بروتين هالجرين بوستيب الأخير. لبروف lipolysis زور ولا شيء مهم هي للبداية. Glycerol is an important substrate. If it is becoming very low, so we need to utilize the proteins and the consequences will be developing after that. So low insulin lead to ketone body formations from fatty. And fatty acid, brain not one bakari. Kata it should be converted to something that can be used by the brain cells, like ketones. Kabuba ketone, brain cell can't one ketone bakari where we have low glucose concentration. Starvation is continuing, and our patient, the ketone concentration increase. أم رقمنا بيز ناكله بركم جماعة الرقمي أم ketone بديو بس increase كبزان decrease كبزان بس أما هو visualizing كيف زين كم زيادة تصوري كي. هل هو مهم بلا ما هو بلا increase يعني decrease باشا رقمك مهم نيا. Ketone concentration rise from our 2 after 3 days and to 7 millimole after 2 weeks. قاعد level like زور زيادة لحد طبيعي. This further reduces the need of gluconeogenesis. أما ما كان gluconeogenesis أو أنا في اسمه النبي لبري كيتون بدي كان ما هي اسمه. And further spares body proteins. هيش وأكاد protein بيلينو بمرحلة كان يدهات. As adaptation to starvation process, 2 factors become important. كانت starvation بردوامة للبروجكت زيادة للبروجكت كم بروجكت. 2 factors يترمان هي مهمة ليه. كيوكن the brain become able to use ketone fuel from requirement of each layer of glucose required from Jana Chinese 140 grams per day. Esa Chinese 40 grams. O3 utilization each key cut ketone again. Number 1. Number 2, the kidneys begin to contribute to gluconeogenesis. The major gluconeogenesis that you have, right? In the liver. The minor in the kidney. كبروسيد بين starvation and hyperthalama kidneys contribute to gluconeogenesis. Patient كمان كسر كمان شوي حتى يجي نخوارله. So after 4 weeks starvation, gluconeogenesis has fallen to 30% of the previous amount. يعني كما كانت شكرا إذا كان مانية بعضين substrate كان ما كان يكتور. Urea nitrogen excretion initially about 12 grams per day, mostly urea. Eventually fall to 4 grams per day, equal amount of urea and ammonia. أما إذا cheap urea cycle enzyme مكاني deplete chemical شكرا كسر خوارد ناخو protein ناخو chemical. So reduction in urea synthesis leads to marked decrease in the enzymatic activities and levels involved in urea synthesis. ام كسا يوريا سنتسيس امبير هم ماكو اكتيفيتي انزيم ثاني هم ماكو اماونت انزيم ثاني اما الاشياء مهمه جي عفر يعني شو That's what. آخر دواء أول الأشياء مهمة clinical point. So during refeeding we have to consider this. How? We give small amount of protein-rich in food diet. Gradually we increase the protein content of the diet until the patient can produce enough amount of enzymes to manage the urea synthesis and urea cycle. أما حصل كما خرجنا كورسا كبار. وعادة ريفيدين جماعة الريفيدين هربوانية كستارفيشن بوكسي في شبيعك جنيك شنروجك نيتواني ونام قال ما ويا كزنبوا قاعد تدرجا كمسيرة كم زور بيهز وما نشكتا أي بنا hospital the same protocol should be applied. هواش به بروتيني بيتي نابه سريعي هم مشتكان زيادة. We need to postpone the utilization of proteins. When all the body fat stores are depleted, the body will use protein rapidly and then follow shortly. But why? Because we need proteins for muscle construction. So this results from a number of causes related to loss of muscles, including serious respiratory infection due to loss of muscle cells functioning. That's not possible at all. Kasi speciale te vinia commenti here.